You don't need the light. It's good for that you put on the light because I don't have slides. I think at that time of the day, slides is a little bit. And I think that the presenters have presented most of the data. I'll tell you my view on this. First, a disclosure. I don't think that every hole in the body should be closed. So if the point is that if you have incidental or non-incidental findings on any diagnostic test, then you have to think individually about the etiology of the stroke, trying to find out whether in this particular patient, what you have found in the heart is actually was the cause of the stroke. Association is not necessarily causation. This is one. Secondly, I think that the recent trial can be interpreted differently, depends who do you ask. If you ask the interventionalist, the cardiologist, some of them will say that those trials were analyzed, or the data that we've seen is by intention to treat, which I think this is the most sound methodology to analyze trials. But then, if you have a negative trial, and if you don't like the results, then you try to dig in and find excuses or explanations why these trials were actually failed. So if you look, they will tell you that the Closure 1 was performed with Starflex. This device is not on the market anymore because of the increased risk of atrial fibrillation that was observed in Closure and others observational study. So they said that as we know that we try to explain the negative results on the endovascular treatment in acute stroke, they say that Mercy device is an old one and should not be compared in the current newly performed devices. They also say that if you look at the RESPECT trial, there were several of the strokes that were put or considered as the device strokes that occurred before the device was implanted. So if you are a purist, you say this is an intention to treat, it's your problem. But they say that per protocol, if you look at per protocol analysis, the device was superior on medical therapy. The PC trial, they say that in spite of the fact you've seen it, 80% relative risk reduction was not significant. They might say this is a type 1 error. There were only 414 patients in this trial. So it could well be that there were, the study was not powered to detect these differences. And in spite of the fact that there was a huge relative risk reduction. So I think that currently, with the current data, there is not, we cannot firmly say that closure is gone. I think that further studies are needed and to look into better design studies maybe. The problem with, for instance, the closure and the other, that the studies were conducted for many, many years. And they encountered difficulties in recruiting patients into the trial. Because some of them in the United States definitely is because the Medicare and reimbursement thing, so people actually closed more patients and didn't put them into the trial. And therefore, it was launching for more than 10 years, I think, in its recruitment. So I think that, again, as usual, selection of patient, this is the magic word that we use for many of our treatment. The same apply to closure, to close or not to close. At least in our protocol, in our hospital, that we have a very good relationship with the cardiologist. Every single patient is discussed with the cardiologist. We tend to apply that probably most of us will do if there is a antithrombotic failure, and in spite of that, the patient had a recurrent TIA or stroke. We tend to close. We tend to close big PFOs with atrial septal aneurysm defined by, at least by our protocol, that's more than 1.1 bulging back and forth of the septum, 1.1 centimeter. And we also apply the TCD plus bubbles, agitated saline. And if we see large PFO with left to right shunt, like the large microemboli is going up, a curtain, what we call the sonographers, I think that in these cases, we tend to close the PFO in spite of all what we've seen in the recent trials. I think that further studies are needed in order to definitely say not to close. So again, I think that we should select high-risk patients that you know exactly that there is a there's a high chance that this stroke is actually caused by the PFO, then we should close them. Otherwise, antithrombotic therapy is the way to go. And if you ask me within this antithrombotic therapy which one I use, I tend to believe the PEAK study, and we use mainly antiplatelets and not anticoagulants. Although I know that the cardiologist will prefer anticoagulants, warfarin or whatever. There's no evidence, of course, with the NOACs, the new anticoagulants, but they prefer the warfarin on, at least our cardiologists. They prefer, but we treat them with antiplatelet. Thank you very much.